Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, as we continue our election series, Stephanie Desmond talks to Dr. Jerry Anderson, a Johns Hopkins expert in health policy. They discuss what the election could mean for the coverage of pre-existing conditions, Medicaid expansion, and drug pricing. Let's listen.
Jerry Anderson, thank you so much for joining us.
It's quite a pleasure. Thank you.
Well, I wanted to talk to you today about basically health and the election. And so we've talked a lot about COVID in a lot of these episodes, but what I really want to focus on is health policy and sort of what the election could mean. And I'd like to start with, of course, the most obvious question, which is about the Affordable Care Act. Talk to me about what may or may not happen depending on how things go in November.
So the Supreme Court is going to hear this case on November 10th. And depending on what they decide, which probably in fact won't be until March or even June of 2021, they typically do not give a decision right away. So we will probably not know what's going to happen for an extended period of time. But assuming that they decide to repeal it, then the question is, will the Democrats have a chance to do a do-over? Because when it passed back in 2000, it was under very strange conditions, and they had to essentially accept the Senate version and couldn't make any modifications. And for the past 10 years, they haven't been able to make any modifications. So the question is, what will happen with the Supreme Court? And then the second question is, who will be in charge in the House and the Senate, and who will be the president during that period of time? So those are the big decisions that have to be done. Then we can talk about, assuming that it gets turned down and they have to start all over again, what it will be like.
And sort of, I know the big questions are about pre-existing conditions. I know that the ACA expanded Medicaid in many places, or helped to expand Medicaid. Talk to me about those issues and why they're important.
So the first one is the pre-existing conditions. So about 150 million Americans have a pre-existing condition. And this would be somebody with diabetes or somebody with congestive heart failure or hypertension. And if I'm an insurer, I don't want you in my plan because you're going to be more expensive than somebody who doesn't have one of these pre-existing conditions. So for the last 50 years, have been designing all sorts of things in my benefit package and in my enrollment period not to get you into the program. And what the ACA does is says, no, you have to enroll these people. And so these people could lose their coverage, or they could make it much more difficult for you to get coverage, or they can make it much more expensive for you to get coverage if the ACA gets repealed and nothing replaces it. Now, both President Trump and Vice President Biden says we totally support having the Affordable Care Act or having pre-existing conditions be included. So that seems to be an agreement, but in all cases, the devil's in the details in terms of how they actually implement it and how, whether or not you can get it, but it's going to be much more expensive, or you can get it, but you're going to have a 2-year waiting period before it's available or something like that. So anybody, and that's many people over the age of 40 years old, have a pre-existing conditions, you've got to be very careful about how the wording works, even if it gets repealed and gets replaced with something else. The wording is absolutely critical. On the second issue that you ask about Medicaid expansion, most of the states have now expanded the Medicaid coverage, and the ACA gives them a very strong incentive to do so. You have the federal government picking up 90% of the cost. Originally, it was 100% of the cost of Medicaid expansion. So it was sort of strange that Medicaid programs and states decided not to do so, because they were getting additional coverage at literally no or very little cost. And in many cases, they were having to provide that care by the state themselves anyway. So it was almost a no-brainer to do it. But because of politics, a number of states decided not to do it. What we've seen over the last 10 years now is more and more states are doing it. Even some of the states that originally opposed it now are finding that the economics are so powerful that they have to do it, and they're a little bit holding their nose to do it, but they are definitely doing it. So we're seeing those fundamental changes occurring.
Mm-hmm. If the ACA is gone, will the federal government still be funding these Medicaid expansions?
So the answer is no, unless something replaces it, because that's a big dollar amount. And so the executive branch alone can't do it. The Congress has to allocate the money. And so the Congress would have to go back and say, oh, we are going to continue to expand Medicaid, and we're going to expand it in this way. And so they could decide to expand Medicaid, but in a totally different approach. So if I've gotten Medicaid expansion in a state and I want to continue it, I'm going to argue for the status quo, even if the legislation gets repealed. On the other hand, there are other ways to do it, to fold it into the original Medicaid program and do other things. So I think the Congress, if it gets repealed, is going to take a careful look at what's the best way to do it. They will probably want to keep Medicaid expansion, depending on who's in power, but the cost is going to be very large. You're expanding about 15 to 20 million people, giving them coverage, and they were able to pay for it in the past by asking and requiring the providers, the hospitals, the physicians, the drug companies to pay for it. Now, what was it in for the drug companies, the hospitals, and physicians? They were getting more patients in their offices. So they were willing to make that trade-off. But now they've got these patients in their offices. And so why would they be willing to give up something else to get this Medicaid expansion? So basically the best deal that somebody on the Medicaid expansion or the states that are providing this Medicaid expansion could possibly get is what's in the ACA. So it'll probably be worse, but it's hard to predict.
I wanted to talk about drug prices. I know it came up in the first presidential debate. The president said now that I believe he compared the price of insulin to the price of water. I want to fact check that with you. And I'd also like to talk to you. I know drug policy and drug pricing is really your thing. Talk to me briefly, please, about the differences we'll see between the candidates there.
So in some ways, they agree quite almost completely about the ideal way to do it. So both of them agree that other countries pay much less than we do. We've done studies showing that for brand name drug, we pay 3 times or 4 times more than what other countries pay for exactly the same drug. So both Biden and Trump agreed that that's inappropriate and should be brought down. Now, Trump has had 4 years to actually implement those and has said in executive order that he wants to do it, But for it to actually happen, he has to write a regulation and get it through the system. And he has never gotten a regulation through the system. So, you can say he wants to, but he hasn't actually been able to do so. And it's certainly in his power to be able to do so for certain types of drugs, and he hasn't done it. On the Democratic side, in the House of Representatives, they have actually passed laws that say we should pay no more than 20% more than what other countries pay for exactly the same drug. Then, once we have that as the maximum that we're going to pay, we can negotiate below that. So we can go to Pfizer or Merck or any of the big drug companies and say, this drug is overpriced. We want to negotiate the price for it. And they have to negotiate. Now, will they accept anything more than 20% above the international price? Anything lower than that? Probably not, but they could. And there are all sorts of sweeteners that could be put into the legislation that would essentially give them incentives to actually negotiate. And that would be to give them a quantity guarantee. So, a place like Walmart says, we're going to buy a huge number of batteries. And they get a huge reduction in price because they guarantee a huge volume of batteries. Well, that's essentially what the federal government could do, is to negotiate a price and a quantity and maybe get a better deal.
And insulin, is it cheaper than as cheap as water?
It is not as cheap as water and has never been. What the Congress has done and what the administration has done is limited the amount that you would have to pay for insulin. And that is no more than $35 a month. So I don't know exactly how much you pay for water, but I don't think I pay $35 a month for water, but maybe we do. So, that's the possibility. But what that doesn't say is how much your insurance company pays for that insulin. And that is a whopping big number. Insulin has been around forever. There is nothing new about insulin. It is the same drug as the 1960s with some minor modification in how it gets dispensed and a few other things. But the basic drug itself is the same drug as it's been around for a long time. And yet the price goes up and up and up. So it is literally 500% more expensive than it was just 10 years ago for no reason. No more research and development, no more higher cost associated with the production of it. It's just more expensive because it can be.
And those prices, well, that particular drug's price is limited now, what I would have to pay out of pocket. There are many others that aren't. And at the same time, the healthcare system is still bearing the burden of the cost.
Right. And so when you go into the hospital and you're getting a very expensive drug for chemotherapy or something like that, some of these drugs are $100,000. That's something that you pay in terms of your insurance premium, or you pay it in the Medicare program, or whoever gets it. If you go to the doctor's office, you also can pay a lot. But most of us see it when we go to the pharmacy to fill a prescription. And sometimes we pay a lot out of pocket. I mean, there are some drugs where we pay $15,000 for that drug, and some of us have $15,000, but most of us don't have $15,000 laying around. And so, that's a huge problem. And so you just don't get the drug, and it's really sometimes very important for your life.
So what you're saying is that the candidates say that they both want to reduce drug prices, but that it actually hasn't happened in the administration that we have currently.
It has not happened where the drug prices continue to go up, and the very expensive drugs are the ones that are driving this. So the drugs that cost more than $10,000 are the ones that are driving it. And these are new drugs. These are drugs that we all want to have in our arsenal, but we can't afford as a society $10,000 drugs, $50,000 drugs, $4 million drugs. We just don't have the resources to pay for that, and to pay for education, and to pay for housing, and to pay for national defense.
And these are issues that the candidates have discussed, and we could see changes depending on who is in office. Is that correct?
Right. And I think there is, again, agreement that we're paying too much vis-a-vis other industrialized countries. But the question is, how do we bring those prices down? So there's lots of different ways to do so. One is just to actually pass a law to say we shall pay no more than 20% above the international average. And another one is through executive action and a few other kinds of activities. So there's agreement that the drug prices are too expensive, and no agreement on how to actually bring them down.
I think I could talk to you about this all day. Jerry Anderson, thank you so much for joining me.
It's been a pleasure. Thank you.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.